detail of it.
ये तार वार ठीक लग रही है?
Investigation,
ठीक
yes,
है?
madam. Greetings from Team Digital IMA. Heart Care Foundation of India, our webcast partner, IMATV and Library are webcast partner. This webcast on a weekly basis is being brought to you by Indian Medical Association and its wing, IMA College of General Practitioners. Hosted by me, Dr. K.K. Agarwal, Honorary Secretary General, and Dr. V.K. Monga, the Dean of IMA CGP. Our partners are Librate, who is our digital partner and online partner, and Librate is basically a patients community who deals with the medical community. The last half an hour part of the session will also have simple questions which are related to general public. So therefore this webcast is not only for doctors but for all healthcare providers. The public part of it is being coordinated by a foundation, Heart Care Foundation of India. We also have eMediNexus, our webcast partner, who takes care of all the logistics of this webcast. And this can be viewed in emedinexus.com. It can also be viewed on emedinews.in. It can also, obviously, it can easily be viewed on IMA website and Heart Care Foundation of India website. Every week we discuss a subject. This year, from this time, we will be bringing you the new BC Roy awardees. BC Roy National Awards are the highest award, like an Arjun Award of sports. These are the highest awards which can be given to a medical doctor. Above them are only Padma Awards, which are open for everybody. But BC Roy Awards are the highest awards for the medical profession. After a long gap, the last awards were given in 2008. 2009, 10 and 11 awards could not be given. 14, 15, 11, 12, 13, 14, there was no MCI. 14, 15, 16 are yet to be given. And this, a couple of days back, Medical Council of India, BC Roy Committee has announced the award list of 2008, 9 and 10. The 14, 15 and 16 will be announced next year. The awards are being given by the President of India on this 1st of July at 1 p.m. in Rashtrapati Bhavan. And it has the same significance as that of a Padma Shri Awards. We will be bringing to you, possibly we will try that all Padma awardees of this year, in 3 years almost like 27 Padma awardees. By sequence we'll try to bring an audience with them and we'll have an interaction with them. We already have started a print interviews with them. And today, in the first of our series with BC Roy National Awardees, we have with us Dr. Neelam Mohan. She is she got the Padma, the BC Roy Award this year in the field of developing a specialty, and that is a pediatric gastroenterology, pediatric hepatology, and that too in pediatric hepatology, pediatric transplant, which she is an expert. Years she was in Gangaram and then she shifted to Medanta, and she has many firsts to her credit. In the last 5 or 10 minutes, we will talk to her about her personal life and personal achievements. But we start with our session on, because she is a pediatric gastroenterologist and a pediatric hepatologist, we'll try to understand some basics of hepatitis. For a GP, it's a very simple formula I teach them. When I teach my GP, I teach them viral hepatitis is of 5 types, A, B, C, D, and E. If you rule out B by doing a simple 25 rupees card test, which you can do it in your clinic, you can charge for it. And if B is negative, then D is also negative, because D will never occur without B. So you can rule out with 25 rupees whether it is B or D or not, you can rule it out. Practically, we'll ask this question to Neelam, practically through a GP we say, C is a chronic disease, may not present with acute hepatitis. So if it is an acute hepatitis and if 25 rupees B is negative, then it is either A or E. In both the situations, the hallmark is the SGOT, SGPT, if it is more than 1000, there are only 3 conditions: viral hepatitis, ischemic hepatitis, or drug-induced hepatitis. If there is no history of drug-induced drugs intake and the patient is stable, means he is walking around, it cannot be an ischemic or ischemic hepatitis, that patient will be in ICU, then practically it is viral hepatitis. And if it is B negative, then if it is an adult, call it as E, and if it is a child, call it as A. So in 25 rupees, you will be able to have a Jugadu test to find out which hepatitis you are dealing with. Today's session we'll try to understand more about hepatitis, and then we will also talk about, in the last segment, something new. And that something new is that up till now we used to say Hep C, Hep B and HIV are incurable. We used to say Hep B is more dangerous than the HIV, and then came the numbers and they said Hep C is absolutely rampant in the society, much more than Hep B, much more than HIV. To the extent some people are even talking about 1 to 5%. And but when we talk to the blood banks, they don't give this number, but we don't know what the number is actually. And the good news is Hep C is now curable. It is unlike, and if Hep C is curable, a time will come when HIV and Hep B will also become curable. And once we say curable, means curable. In 3 to 6 months treatment, hepatitis C can be totally curable, and that too with a total expense of not approximately 45,000, and in cirrhotic cases 90,000. So a time has come for Indian Medical Association to create awareness about the disease, to talk about that Hep C is curable, to talk about Hep C insurance. We need to fight out with the insurance company to see to it that Hep C comes into the insurance. Now government is coming out with universal insurance concept. Government is coming out with an insurance. Somewhere we need to talk about Hep C insurance. That means the whole community get insured specifically for Hep C. And if it is accounting to 2 to 5%, if 100% people pay the premium, then they pay for others who develop it. And you never know who will develop it. Remember, if you are attending your blood sugar camps, which all of us are used to, if you are going for a free blood test checkup, finger checkups, all types of hemoglobin done by finger prick, we are prone to get hepatitis C at any age. Therefore, IMA feels that it's a time for the public or the insurance company to think of Hep C insurance, to fight for the rights of the people who are in Hep C. We'll talk more and more about it, and we'll also talk about when the time will come when the Hep B will become curable. So Neelam, welcome to our show.
Thank you so much.
And we have enough time. We'll talk for 1 hour. If you want to extend, we can extend. There's no problem. This is so basic that even public is watching, even nurses can watch this program even. So we are not talking about advancements, but we are talking about those advancements which the public would know. So me and Dr. Monga will be interacting with you for the next an hour. So first of all, I said A, B, C, D, and E. Redefine them in the same simple language. What is A, what is E, what is B, what is C, and what is D?
I think it was very beautifully described by you. So D does not exist on its own. It needs B. So if you have checked for B and then D, so I think we can talk a little less about D. So we would be left with A, B, C, E. A and E, simple to remember, are due to contaminated food and water, hygiene, sanitation, fecal route. So these are those, and they don't give rise to chronicity. So that's a simple thing. If they come, they hit you, you get
survive
cured,
or you die.
You survive or you die, but you won't keep on living with it. Whereas B and C, they rarely present to you as acute. As you rightly said, that 25, so they rarely. So that is the one which is due to blood transfusions, products. We can talk about how do they occur.
Everybody knows about transmission of HIV. The way HIV
Exactly,
is spread,
HIV. Whether it is blood, whether it is sexual, whether it is mother to child. But what people don't realize, and they keep asking me, suppose they go for a ear prick, or you go to a barber, or you go to a dentist, or these are the things. You go for a nail filing, and then who was using that nail filer. So these are the ones which we don't understand why they've got it without it. So there are so many other subtle ways of acquiring. And now that you've said, I would always like to say that if you get a prick from an HIV person, then even that prick is just like supposed to be.
mini blood transfusion.
No, the risk is for you getting HIV is not more than 0.5 to 2. But the same thing, if I get a prick from a B or a C, the risk is very huge. So that needs to be understood, that the risk is 10 to 100 times more for a prick from a B patient or a C
So therefore,
as
IMA
compared
feels,
to
IMA feels we should abandon HIV program in the country. We should only to have B control program. HIV and HIV will be taken care of by itself. Because
Yes.
it is much more dangerous. Hep B and Hep C are much more dangerous than HIV. Focus on Hep B prevention, HIV will be taken care of.
Yes, so if you're talking about prevention, I would say
Yeah,
definitely
I'm talking
yes.
about prevention.
We can talk about that, yes, the thing we can use is we can use the base of HIV. Today, HIV, you have centers all over the country and all. So most of the experts think that if we go on the shoulders of HIV, it would be a win-win
Absolutely,
situation.
absolutely. So Hep A and Hep B.
Rather than giving them, confusion and that.
so
So we
very
go
simple-
to those people and
Simple
pile up
thing,
there.
Hep A and Hep E. A is in children, E is in adult. The diagnostic is that if SGOT, SGPT are in thousands or more than 25 times the normal, always more than 8 times at the normal, then you're not dealing with any other thing except for viral hepatitis. My first question comes is that when we send to a specialist, they usually go for A or E markers. But at a GP level, as a GP level, do we really need a diagnosis? When do we need a diagnosis that I send for a markers which are costly? Can I manage if Hep B is negative with A or E? I presume E is adult. So if an adult comes to you with Hep E, clinically I know it's a Hep B. Do I really send them markers?
Well, then I'll tell you.
If yes, in which situation? In the
Correct.
routine, I don't want.
Correct.
That means what are the indications of Hep E in
Right.
adults or Hep A in children? That means the person is going into encephalopathy or where he may end up into a complication.
Right. See, first thing is, you have rightly said that generally hepatitis E is more common in adults. Having said that, we do see hepatitis E in children. So sometimes because it is totally a fecal route and they say that if your drains are getting contaminated or there is contaminated water which is coming, and majority of the time it is not only, as an epidemic, if suppose the pipes get, or it can be even sporadic. And things get worse when you get the dual infection. So we sometimes like to see, and I've got what I would see among the data, because I was supposed to give a talk at World Congress on hepatitis E in children. So that's why I was like trying to look at the entire data for the last 10 years. And we realized that I totally agree with you that the percentage of hepatitis E in children would probably be less than 2 to 5% of the total hepatitis that we see. So, you always like to give general statements and I appreciate that. Now, hepatitis, when it is a pregnant person who's coming,
Pregnancy.
beyond doubt you will
I'm
like to do
talk-
the hepatitis
Pregnancy,
E.
I'm not dealing
Correct.
with.
No, I'm just saying.
Because in
So that
Hep B
pregnancy,
is
hepatitis E will have a mortality of 20-25%.
No problem. I'm not.
So I want to know what is it in pregnant person. Then it comes to in adults, what happens is the risk of mortality is very high with hepatitis A. In child, the risk of fulminant hepatic failure, I mean. So in a child, fulminant hepatic failure is 0.1%. That means 1 in 1,000 if they are less than 6 years or so. When they are between 6 to 12 years, it goes up to 4%, 0.4%, from 0.1 to 0.4. And if they get into adulthood, it is 1% to 2% in elderly.
I'm going something with
So what I'm trying to say is, an elderly person who has hepatitis A infection has a chance of getting into fulminant hepatic failure 2%. So that's all we're trying to say. So I totally endorse you that in a GP setting, if he thinks that the pocket is not permitting A and E, I can appreciate. But sometimes if there is a past history of jaundice, or if there is a family history of some liver disease, or you find when you touch the liver to be quite hard, you're not finding it, or you find the spleen is a little, say, more than 3 centimeters, which you should see in an acute. Why am I saying all these numbers? What I'm trying to say is that hepatitis A could be on an underlying chronic liver disease. So that time, I don't want to miss the opportunity of identifying what insulted it. Could this be later on an autoimmune disease, could this be a Wilson's disease in a child? And why? Because both of them are treatable. It is sad when these children come to me and I diagnose autoimmune liver disease, they are already cirrhotic, but if they had history of jaundice 2-3 times in the past. So if you think, so the red hingers which he asked me, if you think the liver is hard, or if you think the spleen is out of proportionately big, or there was a family history of a jaundice or a death or a liver disease, these are the people try to identify
recurrent jaundice.
Correct.
If it's a recurrent jaundice, it's not
Family
a GP's
history,
case. It's not a GP's case.
Perfect, absolutely.
If it is a family history of jaundice,
Or a death or something,
if you have
refer
family
to a
history,
specialist.
you refer to a specialist.
Correct.
If you are finding that patient has underlying chronic liver disease,
Correct.
whatever is the parameter,
Whether the patient is malnourished, some edema,
if you have
ascites,
signs of
spleen,
chronic
liver,
liver disease,
anything,
you
refer
refer
to a specialist.
You refer.
Agree.
I'm only trying to say is non-pregnant in adults.
Absolutely.
You are not dealing with a chronic liver disease. I'm not even including people with alcoholic liver disease associated. I'm not even talking about diabetic liver disease. I'm not even talking about gross fatty liver, because there are coexisting diseases which are.
Correct.
In a simple viral hepatitis, if it comes to GP, where 95 to 98% will recover. At what stage I expect them that they are going into acute fulminant failure?
Perfect.
That's all. That's the time. At
Correct.
the time I refer and let the specialist decide about doing the markers.
Correct. If you think the jaundice is rapidly increasing,
Is there any word numbers for rapidly?
right. So what we mean is there's no numbers, unfortunately.
Something
we
like
would
it's
say
reactive.
more than 5 to 10 a day. I'll just give you an idea. Suppose you see him and he looks, and the next day he's looking very depleted today. Or if you think that the enzymes, have gone up more than 5,000, 6,000, but you always have to see the whole thing in a perspective. Like if the enzymes are getting low and the bilirubin is getting high, it's a bad sign. But if both
Why should it be a bad sign?
because they say that the liver.
That's the cholecystitis phase.
Sorry.
If bilirubin is going up,
Yeah.
enzymes are going down, then
Yeah.
the cellular injury is going down.
No. So sometimes there is not enough left in the liver for the enzymes to be produced. So at that time, what is very important to me is the INR. So what I tell my GPs or my pediatricians that I would like to say is, if you have to spend your money, because he wants me to use his money judiciously, fair enough. Should I spend on a bilirubin, which I can see your jaundice, so why should I do your bilirubin? I'd rather want to know what is your synthetic function, because so I would spend the money on a INR or a prothrombin. Why should I ask for alkaline phosphatase, GGT, OT, PT, if you think it is just viral? So if you are not very deeply tricked, you can do an SGPT, it is more specific to the liver, and you can do an INR. But the question he asked me is, when would you be alert to refer? So the alert signs are rapidly rising bilirubin, or excessive vomiting, or excessive sleep. Now people have this myth कि liver की बीमारी है, इंसान तो ज़्यादा सोएगा, but they cannot be sleeping 16 hours or 18 hours a day. So some child who's sleeping out of proportionately excessively, that child may be getting into mild encephalopathy. So that needs to be looked into, that, or reversal of sleep rhythm in adults. Suppose the person is sleeping more again in the daytime and all, that is also could be an early marker.
And INR?
And INR more than 1.5, but to tell actually definition, I would say 2. But for younger babies, we say 1.5. Because in smaller babies like 3 years, 4 years, the GP may not be able to identify encephalopathy. So to make simple things for children, we say INR more than 1.5, the GP should get alert, or in adults we say around 2. But mind you, post vitamin K. That means the GP should have given a vitamin K, and then the INR is checked.
You mean before doing INR we should give vitamin K?
Right. Now that is a question again which could be a little twisted. If your INR is deranged, then you could give vitamin K and repeat it. That would be better rather than giving an injection. We are talking about BC, so I can't go ahead with the. So one was that. Second was, in India we have, especially in North India, 2 to 5% G6PD deficiency. So people are afraid that if I give you a blanket statement to give vitamin K, the person was G6PD, he started or she started hemolyzing, we are all going to be very worried because that will give rise to increased bilirubin. So everything comes with ifs and buts, and you have to, and that's what is the art of medicine. If medicine was 2 plus 2 4, then 3 of us wouldn't be here. Everybody would be just in. So the art of medicine, it's gray and it's not black and white. So we give you some idea about managing, but at the end of the day, you have to individualize it to a particular person and see which way you're proceeding. If you think you gave a vitamin K and the child started hemolyzing, the hemoglobin would drop. So that's how I would just.
Let me try to. I'm just trying to create something in my mind that in hepatitis A or E, there are 2 types of hepatitis out of 5, 2, A and E. The number 2 considers 2 types of hepatitis, that is A and E. If both, number 2 again, both, means OT and PT again, 2 types of enzymes, GGTP out, alkaline phosphatase. If 2 of the liver enzymes, that is OT and PT, are more than 2000, 2, everywhere I'm thinking the number 2. And if both, that means 2 INRs, one before potash, vitamin K, but after vitamin K, is more than 2 again.
You're right.
2. And if there is a rapid rise of bilirubin which doubles every few hours, again I'm trying to bring the number 2.
Correct.
That it was 2, now it become 4. Rapid doubling
Right.
doubling of 2. The only thing I am not getting a number 2 is, try to help me out, is in constructional apraxia. That means either say, and there are 2 neurological signs. One is constructional apraxia, that he is not being able to draw the angle figures. Along with that, there is an excessive sleep, or there is a sleep cycle change.
Yes.
So,
So there could be irritability, sleep rhythm. If it gets worse, then you will get into shouting.
Then you need number 2 is the second opinion.
And
Absolutely, you are so
excessive
right.
vomiting is also useful.
KK, you really are too
I
good.
just calculated it. For a GP, this
Yeah.
becomes like a sutra,
Yes.
which people can remember.
Yes.
And everything is 2.
Absolutely.
Second opinion. Okay. So in A and E, mostly it is curable. Unless you follow the formula of 2, you are okay. Now we come back to
How do they present? Do you want to know? And
how common is B and C in India?
right
I
now,
directly will spend time on B and C.
correct. So what happens is in BNC, the prevalence that has been estimated in India, according to the recent WHO thing, is around 12 to 18 million of hepatitis C and around 30 million of hepatitis B. So hepatitis B is more. Hepatitis B, on an average, we come into the moderate endemicity, so we are like 3.5%. So we take our population as 1.2 billion or whatever. So it's like 30 million.
3 crore people we are dealing with hepatitis B.
Yeah.
I thought C is more common than B.
No. In India, it is in some zones like that you find more hepatitis C. But if I take the average, the whole country, then it is hepatitis B is definitely twice as much as hepatitis C for the whole
C
country.
is, you are talking about 1 to.
Yeah, so it ranges between 1 to 2% is C, and 3 is say 3.5 to 4, whatever, 3 I would take an average. So that's why the WHO guidelines were saying 12 to 18 for hepatitis C, and B was around 30.
Okay, so both of them are highly infectious, much more than HIV.
Correct.
And I'll talk about.
It's like 6 to 10% incidence of transmission even with a prick, and if you have a mother to a baby, it will be if the mother is HBe antigen positive, then it is going to be 90% transmission to the baby.
So I'll try to work out on the economics. If I get a patient with chronic hepatitis, bilirubin may be low, SCOT, SGPT may be normal or high, And if I'm suspecting B or C, A, I go for a HBsAg.
Yes.
So I do a card test. However, it liable may or may not be. It costs 25 rupees to a GP. He can do it himself. He can screen whether it is Hep B is positive or not. And if Hep B is positive, he
Refers to
wait for 6 months or he
no,
let
I
it?
would see that if
How
if
many
you're-
percentage of them will become negative?
Right. Now, when you have HBs antigen positive, it depends whether you were acute or you were already chronic. So, if your enzymes are normal, the chances are less likely that it would have been an acute. I'm just giving you rough ideas. If you want, then we ask for a test called HB core IgM. Now, HB core IgM is positive only in acute.
Hmm.
So sometimes when our HBs antigen comes positive and my enzymes look normal, so I think maybe it is not acute, but I do an HB core IgM. If your core IgM is positive, it is acute. If it is negative, it is chronic. But the dictum, the teaching, what you rightly said for masses is, we say follow this person for 6 months. Why do we say? Because if it was due to acute, it should have taken care of.
But
And
how many percentage will?
Right. In adults, if you acquire it, then 95% would clear it and 5% get into chronicity. But if you have, we are talking only of B, right?
No B.
And then if you acquire it in a child, if you acquire it in the first year, then it is 80 to 90%. If you acquire it 5 to 6 years, it is 50%. So what I'm trying to say is, newborn was 90, an adult was 5, in between you keep reducing. So if it is first year, it is 70-80%, then a toddler, it is 50-60%, an adolescent, it will be 40-50%, and so that's how you go on decreasing the incidence of clearing it from your body and getting in chronicity.
With that means you're talking in adults 95% will
Clear acute hepatitis B.
clear means
They will get negative.
But in children it's reverse.
Children it is worse.
5% will clear only.
On absolute newborns, it is 5 to 10% only, but it's like 50%. I would say if I take an average a child in the center.
Okay. Then what about that? If I have a Hep B positive, so core antigen, core IgM is only for acute phase.
Correct.
So then what about E antigen and what about?
Correct. So now that I have decided that my HBs was positive, my core IgM was negative, if given an opportunity, or I ask him or her, do you have any previous report? He says, I had a previous report. And if you show that the previous report was also positive, you're sure you're dealing with chronic. Or I find the mother to be positive in the same family and the child to be positive, so my mind is going to say it's going to be the same family mother. So I'm going to be tempted to think about chronicity. So when you think about it, next step you want to decide to treat or not to treat. As simple as that. What does the patient want to do? What do I do, doctor? इससे क्या? Now मुद्दा ये है कि in acute hepatitis B, by the time your liver is going to get damaged, it's going to be few decades, 2 decades on an average, say 20 years. But if you get it, majority of acute hepatitis B in India, we fall into that moderate endemicity. So when do we get? We get it either vertical or in the horizontal in the first few years of life. So majority of the infections in India are acquired in early childhood to small proportion in young adults. So therefore, by the time these people are getting to 30 years, it's a disaster. How much of nuksan to your country that they are not productive people. So that is the issue that we talk about, that it takes. So it is, but you need to treat them. I wish I had a wonder drug. Now hepatitis B was discovered much before C. I think if I'm not mistaken, it was in 1960s, 65, 67 when we discovered B. Hepatitis A was 1947, easy to remember because it's away. And 60s was hepatitis B. and it was 89, late 80s we got the hepatitis C. But the advancements in hepatitis C management, which we will talk subsequently, has been so wonderful. But hepatitis B, we are stuck. So we have given some simple guidelines. What are those guidelines? There are two phases. He loves the word two, so let me divide it into two. In hepatitis B chronic, there are two phases. Immune tolerant, immune active. Immune tolerant, the bug comes into my liver cell. My liver cell thinks, oh wow, friend, both of them are living happily ever after. The virus and my liver cell, they are living. So they are tolerating each other. Immune tolerant. Because they are tolerating each other, your liver enzymes won't get high because they are friends. They are tolerating. So this stage, for me to kick this virus is going to be very difficult. The second phase is immune active. Immune active, suddenly you realize, oh, this is not me. The cell realizes that this is an outside in my cell, and now the cell wants to clear it. So immune active. So the liver enzymes will rise. And when the liver enzymes, so that is the time that if I fight, ek aur ek 11. So I want to fight when the body started fighting. So that is why they say that. But we all know it's a bad virus. We should treat it irrespective. Even if you're not fighting, why shouldn't I get rid of it? Yes, you can individualize it to a person, but I can't give general guidelines. The reason is the present treatment outcome is very poor. Not even 20 to 30% success rate. So what is the treatment I have? I have interferon or peg interferon treatment, which is called the finite treatment. What do you mean finite? भाई एक साल देना. पहले हम 6 महीने बोलते थे, now 1 year. So it's a finite 1 year. So despite giving a finite treatment, my outcome is 30%. And it is worse if it was in the immune tolerant phase. So therefore we are saying that since the disease is progressive slowly, it is taking few years to go into that thing. Identify, check the enzymes every 3 to 6 months, liver enzymes. If you think that the liver enzymes are increasing, that is the time you want to treat. He will say, now, Neelam, you have not talked about DNA to me. I see all guidelines, DNA. But the HBV DNA, if I had to save money, if the liver enzyme are normal, I'm not really going to treat this patient. So in that case, you may not even go for a DNA. But if your liver enzymes are raised, you are in an active phase. The $1 million question is, what is raised liver enzyme? We used to think that the liver enzyme raises to your lab. Your lab could be 60. So upper limit of that, liver enzyme raised 1.5 to 2 times. But if you see the newer guidelines in the American and all, they've realized that probably they take if you take the 20 cutoff or the 30, means for men and women 20 and 30 cutoff, do we need to see that raised? Or what was your lowest once upon a time? Your lowest was 20 and now you are today 40. But according to 20, 40 is raised and it is 2 times raised. Should I see that? So the experts are now realizing that it is very important for us to understand that what exactly we meant by normal hepatitis B. Should we look into the basic normal of population? Should we take only as 20, 30 cutoffs? Should we take the patient's own? So that is a question which I will not get too much, but I'm just giving an idea.
We will, for a GP, we would say that patients, whatever his value was, take it 25 as an average. If it becomes 50,
Correct.
Let the expert decide.
Let the expert decide. I appreciate what he's saying because the expert has to look into the logistics. If it is raised, definitely. And so then comes to the DNA level. Now he's asking me the question of what is E antigen. E antigen is a marker of replication. What do I mean? That means ek ka do, do ka char, do ka aat. So replication marker is E. So if E is positive, you're replicating very fast. So you want to get rid of the E. But having said that, a lot of people in India are in adulthood are E antigen negative. So in children, we keep saying that we look into the E antigen positive. If he is positive, he's got viral marker, he's replicating. But when they get into adulthood, they are E antigen negative. And that E antigen negative is a worse disease. So even if they say your DNA levels are 2000, not 20,000, 2000, you should treat it. Again, the number 2, his favorite. So DNA more than 2000, even if it is E antigen negative, liver enzymes more than 2 times, your favorite 2, you should treat it. If your DNA, so what are all that? They are all signs of replication or immune active state. Enzyme raised, so you are immune active. DNA raised, you are immune. But immune tolerant, so is a phase where they are friends. So your DNA will be very high, in crores and millions, because they're not fighting with each other. So you will find a DNA load of 3 crores, 4 crores, like, high load, but the liver enzymes are normal. So then we individualize it. I would leave it to the expert whether I like to do a biopsy, whether I like to treat a patient, I would say, and now that he's saying, KK knows of my interest in a lot in hepatitis B and C in children, and by the grace of God, the world guidelines which have been written on hepatitis B and C, I'm the first author for Hep C, for World Congress, yours truly, and for hepatitis B, again, I'm representing the entire Commonwealth countries. So what I'm trying to say is that I'm doing a lot of work in B and C, and thanks to him that he keeps talking about societies and serving, we have come in a small way to contribute to the society and get these people to support them and treat them and all. But there's so much in this country, it's not possible for me to do alone, but it's general awareness and the idea which you are saying that IMA is going to come across. I think it's a beautiful idea what step you're taking, that you want to increase the awareness. You want to control something, what is the first step? You want to get thin, what is the first step? You should know you're fat. Half the time I talk to a child, बेटा आपको मालूम है आप मोटे हो? नहीं आंटी, मैं तो ठीक हूँ. आपको मामा ने नहीं बताया आप मोटे हो? नहीं आंटी. So they do not even know that they are fat. If they don't know, how do I know? Then I look at the mother, and the mother, the child is, she says, 8 kilo to ज़्यादा है. It's not 8 kilo. It is a percentage, 20% or 30% more than the expected weight. So first step is awareness, and I think it's a beautiful step that you're going into awareness of realizing
a little bit quickly
this
about
BNC.
Hep B vaccine because it's preventable.
Very
Hep
right.
C is not. So
Correct.
if Hep C is curable, then
Correct.
Hep B is preventable.
Absolutely. So God was kind. We could get the treatment of Hep C first, and now with the wonder treatment, you can eradicate it 98%. But we could get the vaccine for Hep B. So everybody, in fact, it's universal immunization now, and I guess it's nice that the government is also in most of the states, like
So
health is a state
therefore,
issue.
we have a control for both.
We have
Prevent B,
treat
treat C. So get insured for C and
Correct.
get permanent insurance for B by just getting a Hep B vaccination.
Correct.
So-
Absolutely.
so therefore-
Irrespective of your age, please, you need hepatitis B vaccine. People think that when they grow old, they don't need it. It's not true. Because should I check your antibody? Should I spend that money into that? Or should I
Or
give
go
you a
for
vaccine? It
injection
is up to you.
or
Because the vaccine, as he said, is so cheap.
Very
So
cheap.
let's
And a lot of
quickly come back to
institutes
C.
go to
Is there any
clubs and-
fun of giving this hepatitis B to a child who has already got it from his mother?
No. Very
It won't, yeah.
right question. Now, if the mother is positive, pregnant mother, let's
Yeah,
start.
of course.
So the GP should know. It's a $1 million question. If you are pregnant, Mudda is prevention. I don't want my child to get infected. So what should I do?
Yeah.
In the last trimester, the mother, last trimester, the last 3 months,
Yeah.
I want the mother to be given a tablet, an oral antiviral. Lamivudine is very cheap, so depending on your pocket, it is also approved. Tenofovir or entecavir. Now this mother, it is given, sorry to say, may not be with the intention of treating the mother. I might want to give it with the intention of treating my baby.
Yeah.
So if I give the mother in the last trimester, her DNA will come down. Once the DNA comes down, risk of transmission to the baby goes.
Good.
So I will do that, and once the baby is born, each and every GP in this country should learn two things today for hepatitis B. One, there is vaccine available. Two, for every newborn baby, please ensure that the vaccine is given soon after birth. If you are sure that the mother was B positive, then we give immunoglobulin 0.5 ml. It's not very expensive, it is a couple of thousand, but it's going to decide the life of that child. So there are, if you can, I think it's not a matter of 2,000 or 4,000 or 5.
It's
You
a
can,
right.
it is. So I would definitely say that you should give that immunoglobulin and
Quickly-
vaccine.
Quickly we
to
come
the
back to
baby.
C. In C we know there are 2 drugs available, we know it is curable, and C is rampant in the society. A, should I screen every patient for Hep C antibody?
There is a word called Dharam Sankat. I think you put me in a Dharam Sankat. It is very difficult for me to say whether I should screen everybody. So, at least the high risk population should definitely be screened. It would be lovely if you can screen everybody, but with a population of 1.2 billion, I can say, in a meeting, it might get little issues. So you please screen high risk population. Who are high risk? Population is what we are talking about. Anybody who is into drugs or dialysis patients, or history of blood transfusions in the past, or history of surgery in the past, history of taking somewhere a shot where you were not really sure where exactly that shot. So those high risk people you must treat, or somebody coming to you.
See, every poor person has got his shaving done outside on the roadside. He has got his can pricked on the roadside. So what are we talking about high risk? Everybody, you will have blood sugar camps, everybody going for the blood sugar camp.
That's
Tattooing,
nice.
everybody is
I
doing
would
tattooing.
absolutely.
So therefore my first thing
I
is,
always said,
Therefore, my
KK,
first-
that liver is more important than heart. You're a heart guy, but when you love somebody, you always say,
No, no,
Jigar ka
I'm
tukda. So
coming-
I'm a liver person.
I'm saying number one is that if you're going for HIV, go for flu test.
Absolutely.
No HIV alone. Go for Hep B and Hep C also.
Absolutely.
So there is no question of doing only for HIV.
Correct.
Or there is no question going only for Hep B or Hep C.
Correct.
Whenever you're going for
So
one.
nowadays what we do is, like all big hospitals, it's a rule, I think even in government, a lot of them, that whenever a patient is taken for surgery, we always do BCHIV. So that
See, I don't know, but
yeah,
HIV and everybody
so
does.
everybody is now doing
Yeah.
CSA, as you
No,
rightly
she is
said,
now
because it
doing
is
it.
treatable.
Most
So that's the
hospitals
purpose
do
of
it.
getting the awareness that it's always
So-
nice to do BCHIV, and all blood banks do BCHIV.
Yeah.
So you have to identify, but as we said, it is 1.5. So even if you screen
One
100,
one is very big.
it's a
One
big
is very
number.
big.
Good number.
Because talking in a huge
One
number.
is very big. One is very big. So the next thing comes to when I go for
It's
a
more than one.
HCV test, I go for antibodies.
Yes, please.
HCV antibodies.
Yes,
What is the
please.
window period?
Now, actually, that's what they say, that the NAT testing that you want to do, but it is not possible to do NAT testing and everything, but a lot of government hospitals are now doing the nucleic acid testing. Nucleic acid testing is that you're looking for the antigen, the RNA virus, rather than looking for the HCV antibody when you're donating blood. So the window period question comes only when you want to donate blood. And so when you take blood transfusion, it should be a NAT tested blood transfusion. Then the risk is, they say, 1 in some millions that the risk will be there. If not, your risk is going to be 1 in 50,000 plus. So even after doing an
See,
HCV antibody testing, 1 in 50,000 I can get it if I'm not
I
done
am not
that.
bothered about the government policy. I am not bothered about the government rules. I am today concerned about informed consent. Okay, there are judgments from the National High Commission, and all my people should know that if I have not done an NAT testing, there has to be consent of the patient. I cannot tell my patient the NAC testing is not required. If he ends up into that 1 in 1 million or 1 in 150,000, he has all right to sue me for a compensation amounting to 12 crores. So therefore, I cannot say the government policy is for the government people.
Correct.
The government
No,
hospital.
so well taken.
So therefore
So the
my job
window
is,
period reduces to 1 in million
yes,
if you do
so,
NAC
so
testing.
therefore my job is to tell people.
Which is costing you around 1200 rupees or 1000, something like that, for a blood to be tested.
Therefore,
And if you do probably large numbers, the numbers can still come down.
I am only talking
We
about
charge that much in private, so maybe it is less than
NAC
that.
testing is not going to charge you more than 100 rupees in the government
Maybe
setup.
in the
government
biggest.
setup. So what I am trying to say is, our job is, as a private practitioner, our job is to tell the patient, you need a NAC tested blood.
Correct.
If he says it's not available, then you have to give a consent that I'm willing to take a non-NAC testing blood.
Okay.
That means the risk owner is on him. We cannot tell the patient this facility is not available, therefore we are not advising you.
Yeah.
The recent Supreme Court judgment has clearly said the time has come for the doctors to talk about rare diseases. He says all those smaller things which you keep it rarity, the time has come for you to know about. Therefore, I cannot tell a patient that because the policy is not there, because it is costly, therefore I have not done it. It's not possible. I can give you an example of a friend of mine, one of our patients, when my boss came to Chopra, we were seeing never charged him fee because both of them were coming in a villager dress. And once he came back after a year, I said, what happened? He said, Houston गया था, वहाँ पे उन्होंने blockage निकाला, तो सर्जरी करा के आ गया हूँ डेंटल खोली से. And then we came to know that he is one of the richest person of the country, but he was living so simple. He was living like a villager that we never thought that he can afford. So we never gave him an option. So therefore, don't go by the looks of the people.
Never.
Give them the full option.
Absolutely.
So therefore, every blood transfusion, it is our duty. Now there is a recent case which has come to National Commission. The National Commission has ordered that it is your duty to informed consent. Everything you need to tell.
Somebody has rightly said that nowadays medicine is becoming communication, documentation, communication of documentation, documentation of communication.
जो सोचो वो बोलो.
हाँ.
जो बोलो उसको लिखो. जो लिखो वो डॉक्यूमेंट करो. जो डॉक्यूमेंट करो उसको सेव करो.
So that's what I
उसको
said.
सेव करो. उसको सेव करो 5 साल के लिए. Simple documentation is not the answer, and this is a methodology with that. So therefore, hepatitis C, we need to tell about blood transfusion and NAC testing. Similarly, if you are suspecting hepatitis C, you need to know which test needs to be done. So now Hep C is positive. Then I go for RNA.
Yes. So if you have done HCV antibody positive, then in that case you cannot.
Can I, instead of antibody, can I do a NAC test antigen?
No.
Routine?
That is only
For
for
donor.
blood
So
types.
I go for Hep C if antibodies
HCV
are positive.
antibody,
Then I
like
go-
third generation. You can write third generation.
Then
Second generation and all are discovered now. It's only third generation HCV antibody. If
I
you're-
have a point.
If antibody is positive,
No, I have issues. When you say only third generation, then make out a policy. Come with IMA, write a policy that first generation, second generation should not be available.
I think so.
If it is, then we don't talk about
No,
it.
I think we.
Because people will be confused.
Most of the people, what is available in major when you write HCV antibody testing,
Means third generation.
most of us are doing third generation.
So we should
Best
come out
of
with like
them.
doing second generation is.
I think
like
you're right. I think we can get out of that word. But I just wanted to alert, just in case some centers are doing, and I'm not
Okay,
aware.
antibodies
So
are all
HCV
there.
antibody has to be third generation. It's always written at the report.
Then I go to RNA.
So then you have to do HCV-RNA. Why? Because HCV antibody may be positive and yet there is no
No antigen.
no antigen. Unlike B. In B, if your HBs antigen is positive, your HBs antibody is positive, that means you are either cured through vaccination or exposure, but you got cured. But here it is not like a protective antibody. It's not a protective. It is just suggesting you an exposure. So it's not a protective antibody, HCV. Don't think HCV antibody positive is a good news like HBs antibody. So HCV antibody positive is a bad news because it's not protective. But if you have it, still be hopeful. Maybe, like for example, in thalassemics, we did a study to show that only 45% or 50% of those who were HCV antibody positive had RNA positive. So that means I don't need to treat everybody. So you have to do the RNA and then you need to treat the people who are positive. But अब आपका टू गया, पूछो क्यों? बड़ा सिंपल हो गया HCV RNA पॉजिटिव है, चाहे कितना भी काउंट है, चाहे लिवर एंजाइम कुछ भी हो, आपको इलाज करना।
Again, two things. HCV RNA is positive, second is you treat.
Yes.
Two can't be-
So
two can't
you
go
do.
there.
So antibody is positive, do RNA. RNA positive, treat.
And treat with two drugs.
Correct. Treat. Now treatment may what I need. And now we refer to a expert. Why? Because expert will definitely want to do the genotype. The genotype and then give the treatment. But nowadays newer treatments are coming. So
In
that's only
genotype
for
also there are
experts.
two types of genotype.
No. In India there are two common types.
That's all.
Two common types. But there are a lot of genotypes more than.
GP will remember only two.
Okay.
Yeah.
So for purpose of remembering GP, genotype 3 is 70%. And genotype 1 is the remaining 25%, 30.
That's how you can
Whereas
remember like that. You 3 divided by 2, the second is 1. Again 2
So,
comes there.
so genotype 3 is majority, 2/3 in our country, and genotype 1 is the rest. The beauty was, we used to think, all these years, we used to give lectures, we are very lucky people. In India, we have genotype 3, which is easy to treat, because genotype 3 requires 6 months of treatment, unlike genotype 1, when we used to treat with interferon and ribavirin. So those days of interferon and ribavirin, in fact, all the GPs would know this, so today I'm going to give you a shock. In the era of interferon and ribavirin, genotype 3 was a blessing because you need treatment for 6 months and the response to treatment was very high, 70-80%. But in the era of the oral drugs, genotype 3 has become bad because it took more time to treat genotype 3 as compared to treat genotype 1. So genotype 1 is now as good as genotype 3, but there are subtle differences, at least for purpose of India, I might say. In India, we use now oral drugs, and that is just for the heck of naming it, whatever, SOFU we say, and you give, SOFU and ribavirin, and there are 2 drugs called Dacla and Ledipasvir. So I don't want to confuse you, but what I want to say is you choose one drug sometimes. You want
Now
to
the
use.
combination is available in India.
Absolutely,
So-
absolutely, and this combination is so cheap, as you rightly said, that it's become 45,000 for 3 months treatment. But if you're a cirrhotic, you need 6 months treatment. So you get double. That's it. And so now these trials are being done in India, and
So therefore the
I'm
time
gonna-
has come where Indian Medical Association and your specialist organizations should sit together, talk to a banker, and come out with soft loans for HC.
Absolutely.
Simple. I mean, 45,000 rupees, even if they put down 1,000 rupees a month, in 5 years they can take care of their illness. So they should come out with a scheme where the doctor should be the guarantor. The doctors, I mean, those
Absolutely.
doctors who become the guarantor, they can take the post-dated checks from the patients, and one should be able to come out with a scheme. I mean, Hep C insurance and Hep C. I don't know what is Hep C covered in Medicare.
I'm not really sure that I've ever seen a person being treated, getting it
But is
into.
it
So
covered with?
I'm not
we
really
need
sure.
to be sure about that, because even that we need to fight.
Yeah.
That Hep C is not a disease like HIV where you can deny treatment,
Right.
which is also wrong. It is basically a disease much more than by an accident than by a choice. So therefore, mediclaim should cover it, insurance should cover it, soft loan should be available, and every Hep C should be
Which I
insured.
think we don't have now. What
We'll
you're
check it
saying
out.
is a
And
beautiful.
Hep C, I'm only looking for points where IMA can fight.
Fair enough.
Under the banner of
Fair enough.
IMA, we need to find out some issues where we should fight for the community, so that it comes out of a benefit to
Yeah.
the community. So the message today is very clear. Hep C
before we
is,
go
I'm not closing.
Ah.
Up till now we have said is A and E are two common diseases in children. In children we have A, in adults we have E. There are markers. If you find markers of chronicity, or if you find rapid deterioration in an acute jaundice, refer. Hep B, always look for, in Hep C, always try to involve a specialist with you. And the message is Hep B is preventable and Hep C is curable. Dr. Munga.
And we talked about genomes and everything on that, till that level for a GP. But, you know, even now, even in Delhi, I'm practicing as GP. Even now, you come across most of the people who have gone to a Jadewala or a quack.
Wonderful question.
And then they are coming back to you when
Right.
the disease has become advanced, you know.
Right. Now, what I want to say is that acute hepatitis, majority of the
Self-limiting,
time
yeah.
is self-limiting.
Yes.
So they think it is the Jhadawala did it.
Yeah, yeah.
But actually it was otherwise
time
also
that has
going to
taken
be
care of them,
self-limiting,
yeah.
which we need to talk, and most of the GPs know about it. But the question is, what you said is when the people come to you in a late time, you know, that's what you're worried about. Now, regarding the chronic, if it is chronic, it's a totally different thing that we're talking about. And in an acute thing that you need supporting, today we didn't get time, and I hope KK will call me again. There's so much to talk about, like, you know, today when we had this WhatsApp forum, I had 4 or 6 questions. People wanted me to talk about Silimarin. People wanted me to talk about Live 52.
That's right.
People wanted me to talk about Urso.
Because
So,
they claim that
you know,
hepatitis B can also be
it's
reversed.
like a really important Pandora to be, you know, to be talked about. And what do you mean by self-limiting? When do you think you should worry? When do you? There are so many things. Can it always go in 3 months? Can it go in? Can it continue to 6 months? What are the complications of hepatitis A? What if you have God forbid you got a rape with somebody? So what prophylaxis I should use? What if somebody is pregnant and gets exposed to, you know, a child in the house who's hepatitis A? Should I suggest the mother something? Or, you know, the child is sick, a chronic liver disease patient, and you get in the same house Hep A. Should I protect? We could not talk
All
on
these are
this.
the issues.
So we will talk second time, which is on protection. Can I do something for prevention in the terms of vaccine, or pre-exposure, like, you know, I'm going to a country where there is too much place, where there is going to be crowding, my child is going to a crowded place, so what should I do? Sort of a thing, you know.
Yeah, yeah.
Or if you are a health worker and you're dealing with sick people who are acute hepatitis A and E, will I have the risk? Should I protect myself? All that we could not.
And role of diet in hepatitis A and B.
Absolutely. So
People are so
you have
worried
to call
about
us
it.
again to talk about the diet, these drugs, the herbal medicine. And to be honest, who am I to throw away the herbal medicines? I'm no one.
So
Right now, I don't have knowledge.
time doesn't permit me to carry it further. We will have one more specific topic for prevention. Today we did talk about that which hepatitis are curable. We will talk about prevention a lot, and I kept it for the end in the next couple of minutes. Me and Dr. Munga congratulates you for receiving your
Sure.
VC Roy Award,
Thank you so much.
which is
I
a big
really-
feather in your thing. In 1.5 minutes, just tell us about yourself.
Well, I think I would start by saying that I give this tribute and dedicate the award to my parents first. And because it was my father's dream that I become a doctor, and then it was my dream that I wanted to do something which is very new and not available in the country. So it was in the 90s, mid-90s, that I wanted to choose a subject, and I was trying to choose between cardiology, liver, genetics, and couldn't understand, and I decided no, gastroenterology and liver, because I thought liver was not much looked into at that time. And you know, I think the late Prime Minister Rajiv Gandhi had come back and had said that why in my country transplants are not being done, and then you know that Human Organ Donation Act. So I used to read a lot about it, and I realized that yes, it's quite a big shame that we are not doing something. So I decided that I wanted to do more about hepatology and transplant. So it was after working in All India Institute for 2 years, and I thank my mentor, Dr. M. K. Ban, Dr. M. K. Arora, Shinjini, they were there to guide. But in a couple of years, I realized that things were much more than just doing that work, gastroenterology. So that's how I went. They brought to Birmingham Children's Hospital, and I worked a couple of years there, where he loves the word too. So I did a double shift. I used to work clinically from the morning 9 to 5 and then get into research from 5:30 to in the night, because I just wanted to chase everything and I wanted to do everything too fast probably. So those couple of years I ended up getting a lot of exposure in GI, liver transplant, wrote a lot of papers also, and then came back and joined Sir Gangaram Hospital. They gave me an opportunity to start, and I would like to thank Dr. Sama, because he was a mentor who could see that I want to do something different, but the pediatricians found it ridiculous that I don't want to give vaccination or immunization or do normal newborn care. Why do you want to live? So they thought it was not, but I think Dr. S.C. Arya had the vision to support me, and they said go ahead. So I started as an individual person, and as he would say, Hati ki chal, I just walked, and it was difficult at that time. It is easy now to say it's all, but at that time, you're working all alone in some field where not many people were into hepatology and transplant and all alone into it. And so it was definitely a struggle till 2004, where I did at least it was a break for me. 15th August was the day. So it was an independence for the country and independence for me, because that was the first liver transplant that we did, which was a cadaver transplant. And so I was like parked in the room for 1 week, didn't go out of that room because I wanted it to happen, and it happened. And then God was kind and it went on. So I finished with the 50 transplants there in Gangaram and established the first teaching, the fellowship, and getting the training. And I had a lot of support from K.K. Agarwal, who would understand that I would get upset about things that I'm not able to do it and all that stuff. But I think the work, as you rightly say, you should be very sincere with what you want and get dedicated and put yourself totally into it and look into the micromanagement of a patient. Because I've never been a patient who just did 9 to 5, doctor, and I would get into the micromanagement of the patient. And then today I'm really happy, because my dream was to set up a department. What do you mean by a department? Department is not with 2 people. Department means like I have right now at least 14, 15 people working. So that's a department. And it's like all these people working in just pediatric gastroenterology, hepatology, transplant, and set up the entire motility work in the country, not, children doing anal manometry, esophageal manometry, reflux pH, impedance, and endoscopies, ERCPs, transplant work, and getting into research. So we have a team who's looking into the research team, into that. We could not actually do much into stem cells, to be honest. We tried, but I think the support from the country right now is not so much for me to get into the hepatocyte or stem cell work, and I think that there's a lot much needed. So I decided clinical work was more interesting, and so that's it.
So we can only on IMA side and my personal side wish her another number 2. From the first national award, she goes for the second national award, and then we will again celebrate the day she develops and gets the second national award. That's all for today. Me and Dr. V.K. Monga say goodbye to you. We'll come back next Thursday with one more topic. Till that, goodbye.
पीछे रहेगा celebration हो गया